Hello friends, let us now learn some important points about the febrile seizures. Febrile seizures are the most common cause of seizures, especially in children less than 5 years of age. Febrile seizures are the seizures along with which occurs when there is fever that is more than 100.4 degrees Fahrenheit without any evidence of CNS infection in the age group of 6 months to 5 years is called as febrile seizures. Febrile seizures are those seizures which are associated with significant fever with more than or equal to 100.4 degrees Fahrenheit without any evidence of CNS infection in the age group of 6 months to 5 years is called as febrile seizures. These febrile seizures can be divided into two types. One, we have simple febrile seizures. Second, we have complex febrile seizures. Simple febrile seizures are actually generalized seizures which lasts for less than 15 minutes and there is no recurrence in 24 hours. In complex seizures are mainly focal seizures which lasts for more than 15 minutes and recurrences are common in complex seizures. Then, how are you going to manage the febrile seizures? Febrile seizures can be managed if the seizure lasts more than 5 minutes. Then if the patient is at home, then you can advise the baby parents to give rectal diazepam, or we can also give buccal or nasal midazolam, and the child is put on left lateral position. Then if the seizure is more than 5 minutes and if the child is in hospital, then we can start IV lorazepam or midazolam can be started. IV lorazepam or midazolam can be started. No long-term anti-epileptics are recommended in management of simple febrile seizures. What are the risk factors of recurrence of febrile seizures? The risk factors of recurrence of febrile seizures include if the child has younger age or shorter duration of fever or lower temperature, or if the family history of febrile seizures is present, then there is increased risk of recurrence. Younger age, shorter duration of fever, lower temperature, or family history of febrile seizures. Then to decrease the risk of recurrent febrile seizures, we should give intermittent prophylaxis is recommended to reduce this risk of intermittent prophylaxis is recommended. That is, we give oral clobazepam or diazepam is given for the first 3 days of fever. For first 3 days of fever, whenever the child has fever, for the first 3 days of fever, we give oral clobazepam or diazepam. Paracetamol or any other antipyretics does not decrease the risk of recurrence. So this is mainly given for children in younger age, shorter duration of fever which has led to the seizures, or lower temperature leading to seizures, or in family history of febrile seizures. In all these cases, we give this intermittent prophylaxis. Then, if the child today has febrile seizure, what is his risk factor of epilepsy in the future? That the risk factor is if there is history of complex seizure, which is a type of focal seizure lasting for more than 15 minutes in duration and frequent recurrences. If there is history of such complex seizure, or if there is neurodevelopmental abnormality, any neurodevelopmental abnormality, or if there is shorter duration of fever led to the epilepsy, led to the seizures, or if there is family history of seizures, then there is increased chances of these seizures to be converted to epilepsy. So this is about febrile seizures. Then one more important thing about status epilepticus. Status epilepticus is any seizure which is lasting for more than 5 minutes or multiple episodes of seizures without gaining consciousness in between, or a child too is brought to the medical facility with ongoing seizures, then we call it as status epilepticus. If you find a baby with status epilepticus, then management includes, first and foremost, you will have to see the normal ABC. You will have to see that airway, breathing and circulation is intact. Then put an IV access and rule out if there is any hypoglycemia or hypocalcemia, because if there is hypoglycemia, you should start the baby on glucose dextrose infusion. If there is hypocalcemia, you should correct the hypocalcemia. Only then the seizures will, the main cause should be corrected. Then after ruling out that, you can give IV lorazepam or midazolam. You should start it with IV lorazepam and midazolam. Even after giving this, if the seizure persists, then we can give injection. Phenytoin is given in the dosage of 20 milligrams per kg loading dose. You can give injection phenytoin, that is loading dose. Even after this the seizures will persist, then you can repeat the injection phenytoin in the dosage of 10 milligrams per kg. If even still even still after that, if seizures persist, then we can give injection valproate, or we can give injection levetiracetam, or injection phenobarbital are given. So if we start with, if there is any episode of status epilepticus, that is if the seizure is lasting for more than 5 minutes, and if there are multiple episodes of seizures without gaining consciousness in between, or a child is brought to the medical facility with ongoing seizures, in such cases you will have to start the baby with IV lorazepam, or you should start the baby with either IV lorazepam, or you can start the baby with midazolam. And even if still the seizures are continuing, in such cases we should give injection phenytoin 20 milligrams per kg as loading dose, followed by injection phenytoin 10 milligrams per kg. If even after that, if the seizures are persisting, then injection valproate or injection levetiracetam are given, or injection phenobarbital are given. So phenobarbital is given. Then the next disorder which is important here is about the epilepsy. Then we will learn about the epilepsy. Epilepsy is presence of at least one unprovoked seizure. There is presence of at least one unprovoked seizure with either seizure recurrence or sufficient clinical or EEG abnormality. So we have epilepsy syndromes with good prognosis. So we see 5 epileptic syndromes with good prognosis. So I will just first write them. Okay, epileptic syndromes with good prognosis include, this is good prognosis, these are benign neonatal seizures. These occur in neonatal period, and these are called as 5th day fits. Then we have benign infantile seizures. These are the seizures which occur in infants. And we have benign childhood. This is benign childhood epilepsy and with centrotemporal spikes. Benign childhood epilepsy with centrotemporal spikes, or we can also call them as Rolandic epilepsy. And these are seen in almost 3 to 13 years. Okay, these are good prognosis. And the other, we have two more which are good prognosis. One, it is childhood absence epilepsy, also shows good prognosis. This childhood absence epilepsy is seen in children between 5 to 8 years of age. This benign childhood epilepsy with centrotemporal spikes or Rolandic epilepsy is seen in 3 to 13 years. Then we have juvenile myoclonic epilepsy, which is seen in 12 to 18 years. So these are the epilepsy with good prognosis, that is benign neonatal seizures, benign infantile seizures, benign childhood epilepsy with centrotemporal spikes or Rolandic epilepsy for 3 to 13 years, present between 3 to 13 years. Then childhood absence epilepsy present between 5 to 8 years, and juvenile myoclonic epilepsy present between 12 to 18 years. So first we will see some important points about childhood absence epilepsy. In childhood absence epilepsy, as the name says, there is no aura, no post-ictal phase. The child will just have eye fluttering or lip smacking. This epilepsy is actually precipitated by hyperventilation. It is precipitated by hyperventilation. If we take EEG shows 3 Hertz spike wave pattern is seen in the EEG. And the drug of choice for childhood absence epilepsy is ethosuximide or valproate is the drug of choice in childhood absence epilepsy. Then the next epilepsy is juvenile myoclonic epilepsy. This juvenile myoclonic epilepsy is seen in adolescents, and as the name says, there is myoclonic jerks are seen, and there are history of drop objects, and it is most commonly seen in early morning. The drug of choice of juvenile myoclonic epilepsy is valproate. So if you see the drug of choice for focal seizures in children, it is the focal seizures, the drug of choice is oxcarbamazepine is the drug of choice, followed by carbamazepine. Okay, then if you see the epilepsy syndromes with poor prognosis. In epilepsy syndromes with poor prognosis, we have first, which is Ohata-Hara syndrome, which is seen in infancy. Ohata-Hara syndrome in infancy. Then we have Rasmussen syndrome, which is seen in 6 to 12 years of age. Then we have Dravet syndrome, which is again seen in infancy. Then we have Lenox Gstar syndrome, which is seen in 3 to 10 years of age. And this Ohata-Hara syndrome can lead to one more disease, which is West syndrome. So these are the epilepsies with poor prognosis. That is, most of the named epilepsies like Ohata-Hara syndrome, Rasmussen syndrome, Dravet syndrome, Lenox Gstar syndrome and West syndrome. Ohata-Hara syndrome, Rasmussen syndrome, Dravet syndrome, Lenox Gstar syndrome and West syndrome. So now let us learn some points about first West syndrome. So West syndrome has a triad. It includes a triad which shows the infantile spasms, which are also called as salam attacks. These are also called as salam attacks, which is infantile spasms, and there is delay in development. There is developmental delay is seen here, and we see hips arrhythmias are seen on EEG. Okay, so this is West syndrome. The drug of choice for West syndrome is injection adrenocorticotropic hormone, whereas drug of choice in West syndrome in tuberous sclerosis is vigabatrin. Normally the drug of choice of West syndrome is injection ACTH, but if it is associated with tuberous sclerosis, then the drug of choice is vigabatrin. Then we have one more type of seizures, which is Lenox Gstar syndrome. Lenox Gstar syndrome occurs in between the age group of 3 to 10 years, and this includes the developmental delay or intellectual disability is seen here, and this is associated with seizures of multiple seizure types are seen in Lenox Gstar syndrome. There is delay in development or developmental delay or intellectual disability with multiple seizure type, and if you see the EEG, it shows 1 to 2 hertz slow wave and spike pattern is seen in the EEG, and it is difficult to control this Lenox Gstar syndrome even after giving multiple anti-epileptics. Then we have last topic of this class, which is about breakthrough seizures. Breakthrough seizures, a child is breakthrough seizure is something if a child who is a known case of seizure disorder on anti-epileptics presents with an episode of seizure. Even the baby is on drugs, but still if she lands up into seizures, then that is breakthrough seizures. If there is history of breakthrough seizures, then the first drug used in the treatment is, first you will give injection lorazepam or midazolam is given. If the child is not on maximum dose of anti-epileptic drugs, then give half of the loading dose of same anti-epileptic drug. Okay, along after this you should give, if the child is not on maximum dose, then you should give half the dose of the same anti-epileptic drug which she is using. That means if, for example, if the baby is using valproate, then we can give it in the dosage of 20 to 50 milligrams per kg per day. And if the baby is on phenytoin, we can give 5 to 8 milligrams per kg per day. If the baby is on phenobarbital, then we can give 3 to 5 milligrams per kg per day of drug can be given. So this is about breakthrough seizures. Thank you for watching.